Thank you very much. So I've been here for the first time 2 years ago. My name is Tomasz Miskov. I'm 26 years old. I had the Ewing in 2023. And today I was invited by Dimo to share some patient perspectives on local treatment. So what I would like to do first is just take you through my treatment so you get a bit of a story of what I went through. And then at the end, I have 3 questions and maybe some thoughts that came up from everything that has been said so far. Okay. So I started to have a back pain around March of 2023, and luckily, fairly quickly, I managed to get a GP visit, at which point I persuaded the GP that the back pain is not just a random back pain that can be solved with some paracetamol, and he got me an X-ray. Right after an X-ray, a few hours, they called me from the hospital that something doesn't look very well and I should do a CT scan, which did not sound very well indeed. And very quickly we did a CT scan, at which point we discovered a mass in the thoracic area of my spine that was 6 centimeters in the largest diameter. At that point, it was obviously unclear what are we dealing with, but I was fairly quickly run through an MRI, and the pictures that came from the MRI to us and my family looked quite horrific. So it was clear that at this point the tumor is sort of around 3 parts of my vertebrae, and there's also an extension into my spinal cord area, which started to explain why I was a bit wobbly on my legs and why I felt sort of tingling in the bottom area of my body. Here you can also see the other picture of it. So after the MRI, I got the needle biopsy, and then within a few days, we got a positive outcome that this is Ewing sarcoma. So at least we knew what we were dealing with, but as you can see, it took about a month to go from I really have severe back pain to, okay, you have Ewing sarcoma on your back. Luckily, at the time I originally come from Slovakia, but at the time I was studying in the Netherlands, and that's where I also started my treatment. And I say luckily because as patients advocate, we have discussed this. Eastern Europe is still quite behind what the Western Europe is doing in the UK. So I followed the traditional latest approach, and I started with chemotherapy right on the 13th of May. And as you can see a bit from these videos, I was really wobbly on my legs in the first treatment, but already after 10 days, I could bike again and walk again. So the effect on the shrinking of the tumor and so the releasing of the pressure of my spinal cord was fairly immediate. I'm gonna run through it pretty fast so we get to the questions. I done normal 8 rounds of chemo, and after 8 rounds of chemo, so roughly after 3-ish months, nearly 4-ish months, we started to discuss with my treatment team whether to do a resection or a radiotherapy. At this point, we had pretty good results from the comparison MRIs, where we saw around 90% of shrinkage of the tumor. And so essentially the decisions came down to, can we avoid as much spinal cord damage as we can? Can we minimize my long-term disability? And can we achieve R0 margins? At the time, just so you have an idea, I was studying data science, so I was reading actually a lot of studies on Ewing sarcoma, and I had pretty spicy conversations with my treatment team, really going down into what we could do. The outcome here was, we know that all of these things are something that we want to achieve, especially the R0 margins. So the decision was that we will do a radiotherapy and hope that this can further shrink the tumor and thus allow us to either not do surgery, which was my hope at the time as I was going through chemo and it was all so rough and I really didn't want to do another surgery and face potential more complications. And if we will have to do surgery, then hopefully at least the tumor shrinks and we will be able to achieve R0 margins with a smaller cut than what we would have to do. And so I started radiotherapy at this point, and I did proton radiotherapy in Delft, where at the end of November, I went through 28 fractions, and I was following the treatment of chemo throughout radiotherapy. So I was doing the two concurrently, and I finished chemo at the 23rd of November, so roughly 6 months and 10 days since I started the very first chemo. So in that time, I did all chemo and all radiotherapy. And now my favorite question was, do I have to do surgery or not? Which I was really hoping I will not have to do. But as Dima was showing some of the previous studies, we basically don't have very good results on whether definitive radiotherapy is as good as surgery. And so the question sort of came down to, can I avoid surgery, and should I if I can, right? And the question was that, yes, maybe I can avoid surgery because we have some retrospective cases where we basically saw that the peripheral survived just fine with definitive radiotherapy. But we don't have prospective randomized trials that tell us, yes, one is as good as the other. And so then the answer was that probably I should not avoid resection. And so with my team, we decided that we will do the surgery. And that will also lead me to my questions at the end, which is how big of a surgery should we do? At the end, I ended up getting a 2 months break to sort of recover from all the treatment I had so far. And I think there's also something interesting for the fact of if pre-operative radiotherapy has an effect on potential complications with the surgery. If you take 2 months off to recover, does it have an effect then on those complications? Maybe they grow smaller in the time. But so at the end of the day, my surgery looks something like this. From my 6th thoracic vertebrae, they cut out the transverse process and the spinal process. And you can see on my beautiful illustration where sort of the tumor pit was. And that's what we decided to cut out in the end. With that, I also got to cut out a piece of my rib and intercostal nerve. So my spine looks something like this at this point. Okay, so that's the resection. So 1st of February 2024, that's when I finished my treatment, nearly 8-ish months afterwards. And of course, what followed was a pretty long recovery until I felt normal and I can move everything. So it was quite a success. I'm really grateful for the entire treatment I received in the Netherlands. Which brings me down to the questions I wanted to discuss in the end. I have 3 questions and then maybe some more ideas. The first question is, did I need the surgery, which is already something I alluded to. The second one is, was the extent of my local therapy right? And I say local therapy because both the extent of the radiation that I received and the amount of bone that was cut out of me. And finally, was the timing for the local therapy right? And I picked these 3 questions because these were the 3 questions that we were sort of discussing throughout the entire treatment as we were progressing through the chemos and figuring out what are we going to do next. I have this quote from the cancer.gov that has a really good summary on the entire Ewing studies that we have, but I don't think I have to say that to this crowd. Which is that we do not have any randomized trials that directly compare surgery with radiotherapy. And I think, especially in cases like mine, where we are dealing with vital organs all around the tumor, it might be worth it figuring out whether the surgery is needed or not. My input here is that I really wanted to avoid surgery. I did not in the end, which I hope is going to really help me survive. This was sort of my rationale. Okay, I'm going to go through this because I want to maximize my chances of surviving. Hence, I am willing to accept greater risks than not. But I think from also being involved in EEC for a while, what we could do here, and that's more on the statisticians, is that we could run a non-inferiority trial between the radio and surgery, something like what we have been doing with patient advocates for the trabectedin trial in the recurrence trial that's running, where we are basically just saying We don't want radio to be better than surgery. We just want to check if it's as good as surgery, and if we are willing to accept 2, 3, 5% decrease in survival, but for better functional outcomes, maybe it's worth doing it, right? If this is not possible, then hopefully having proper decision forms can at least tell us how are people in different countries and different hospitals deciding whether to do a surgery or not. I think I went through a pretty extensive decision process with my oncologist, my radiologist, and my surgeon, which was not documented, and thus we cannot take out anything from it. Of course, it's biased, it's retrospective, but if there was a form which we would collect, where we basically say, we have decided to go for surgery because of these 5 outcomes, and we have graded them on a scale from 1 to 5, and at the end of the day, we can at least finish the treatment and say that before the actual surgery or radiotherapy happened, this was our thinking, and here is a form to represent it. I think that would already be data that then statisticians could work with to maybe not achieve the same level of certainty as a randomized clinical trial, but at least have a good data to work with. Then second was the extent of my surgery right. And so the question I leave here is, should we apply local therapy to the entire extent of the pre-chemo disease? Which I think is still something that's discussed, but it's sort of impossible to do in so many cases. And so then we discuss, in my case, how much of the bone should we cut, right? And at the end of the day, we have decided to cut the 2 pieces of the bone from my vertebra that I showed you, because that was sort of the largest possible amount we could have cut without any huge implications. But was it the right amount that we should have cut? Maybe we could have cut less, and I would have even better functional outcomes that I have right now, right? I think this is a nice question to ponder, but I think, one, the answers differ for surgery and radiotherapy. Obviously, you can irradiate more amount of tissue than you can cut out, but then, again, there are also problems with it. It also differs based on the location of the tumor. But I think lastly, it's basically impossible to randomize on, because you are gonna get Ewings in so many different places. You cannot randomize people who have it both in femur and slightly different places of femur, and then you tell one, or you cut 2 centimeters above where it was, and you cut 4 centimeters above. I think it would be really difficult. So possibly we can again do the same thing that I said with the first one, which is, let's at least collect data before these decisions are made on how the decisions are being made. I'm also just a patient advocate who just reads a bit of studies, so I don't know, maybe this is already being collected. I'm just sort of trying to voice my ideas from being down the pit. Then lastly, was the timing of the entire thing right? I think there is no question about chemo being first, and I think here everyone is convinced of that. When I had Ewing, I started so I was living in Netherlands where I was diagnosed. Then I flew back to Slovakia for a little bit because my parents wanted me to be home, and then I returned back to Netherlands to do the actual treatment. But while I was in Slovakia, we have talked to some doctors there who were basically like, guy, you are losing your ability to walk, we should operate right now, you have a tumor on your back, right? And luckily we didn't do that, but I am saying that chemo is no question maybe in the West, but in the East it still might happen that we just rush through it because of the immediacy of the problem that's going on, without actually checking, is this Ewing, what should we do? I have put here the results of this study, where I think it's an American study, where they basically looked at both survival, the long-term overall survival of people who got local therapy earlier rather than later. And you see that there is a significant difference. So getting it earlier rather than later makes a difference, but what is more important, getting chemo without delays or getting local therapy earlier? Throughout my entire treatment, I was very much encouraged to sort of shield myself and stay healthy and exercise and blah, 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 just so I can get chemo every 2 weeks. So I think, again, here, I don't have a good answer to how to study this or how to define the trial, but I think we also have to be careful about striking a balance between just doing the surgery and that potentially delaying the chemo treatment or the other way around. That's my last slide, but what I would also maybe like to say, and maybe it's not going to be super popular here, is that although all of these questions are interesting, both from the perspective of an individual case like mine, of like what would be the optimal thing that I should have done, and also just from the case of studying it, of intellectually being interesting. I think what we are talking about are minute percentage differences in survival, and putting all the effort, both financial, minds, all the people into it, might not be worth it then compared to trying to trial new drugs that would actually make a difference, especially for people who are having recurrences, or trying to find completely new approaches to what we are doing, such that this entire crazy treatment doesn't have to be reality for the people in the future, instead of trying to extremely optimize the already existing treatment, which we know that, okay, works kind of fine, could be better, but that's sort of the final thought I would like to leave you with. Thank you.